Adharshila Renal Care Project has launched a special initiative, PD-TAME, which trains doctors pan-India in pediatric nephrology. And we have trained about 250 doctors till date. This course has been designed and the vision has been translated into action by two visionary pediatric nephrologists who are with us today.
I started practicing pediatric nephrology in large public hospitals, and then we realized that acute care nephrology is intensely skill-based. It requires a lot of skills to be imparted on critically ill patients, and the engagement of young postgraduate pediatric students, postgraduate fellows, and at times even adult nephrologists was lacking. So the problem was that we were looking at too many critically ill patients with acute kidney injury requiring a whole lot of complex therapies, and we were overburdened with patients. So at that point of time, my initial training also as a pediatric emergency medicine physician came into play. So it was in 2009, myself and Dr. Prerna Batra, we had undergone a 1-year fellowship training program of pediatric emergency medicine as well, under the mentorship of Dr. Binita Shah from SUNY Downstate, New York, Dr. Sagar Garmalkar, at that time was working in the University of South Florida. Currently he works at Sarasota Memorial Hospital in Florida, and Dr. Prashant Mahajan from Children's Hospital of Michigan, USA, along with the ultrasound skills which we learned from Dr. Sanjeev Bhoi from All India Institute of Medical Sciences. We thought of incorporating the engagement of students.
That's so interesting. And Dr. Mishra, what do you feel is going to be the impact of this program pan-India in terms of reaching out to all the rural and semi-urban areas?
Ma'am, by training these young fellows, senior resident, junior resident, younger faculty member of the medical college across the country, as you know that this is the 4th training program and many are pipeline in the future, and we have to reach across the country in all the states, and our estimate is about in the first phase we can cover 1,000 participants in the skill up acute care nephrology, especially dialytic support to children who suffer from acute kidney injury, which has a very high morbidity and mortality. Even mortality ranges from 30% to as high as 70%. Survival can be improved. One. Second, targeting these participants will help us to spread the knowledge and skill in this field to other generations and other parts of the country, so that morbidity, especially the mortality of acute kidney injury and children of chronic kidney disease who are on maintenance hemodialysis, can be reduced, and facility can be developed, and these services can be provided adequately.
So how did you both think of working on the module together and preparing the course curriculum?
It took us about a year. Initially conceptualized the module, its theoretical component, covering basically acute peritoneal dialysis, automated peritoneal dialysis, hemodialysis, continuous kidney replacement therapy, plasma apheresis, with sick children along with mechanical ventilation, which is very important when hypoxia is there. You all know that airway, breathing and circulation are very important in survival of, in that way, any sick child, any patient, besides dialytic support. So theoretical aspects we have developed a module, and then case scenarios for each skill, and certain questions, leading questions, and then its explanation by the expert on each table in a batch manner. 7 to 8 participants are placed on a table, and after a brief 15 to 20 minutes theory lecture presentation, we rotate and go and solve their problem. And in the post-lunch session, hand-on training like how to put the catheter, PD catheter, central venous catheter, identify the circuit of hemodialysis machine, how machine works, what are the problems they face. And then Dr. Abhijit will highlight point of care ultrasound we have incorporated in depth,
Yes.
and he has enough experience in focus, that is point of care ultrasound, integration of focus in this field, acute care nephrology.
Would you like to elaborate
yeah,
on that?
so a unique aspect of this module is incorporation of mechanical ventilation and focus along with the dialytic therapy. Now, Dr. Prerna Batra from emergency physician and intensivist from University College of Medical Sciences, and she has helped development of this portion of the module in a very lucid way, which is understandable to the postgraduate student as to how these kits should be mechanically ventilated, what are the pros and cons, and how settings should be changed, and how the patient should be monitored in these patients. Apart from that, ultrasound is an excellent tool for, in a non-invasive way, evaluating fluid overload, and also used for catheterization of introducing the central venous catheters, and also evaluating the basic pathologies of the kidney right in the ER itself, in the emergency room itself. One of the major problems with most low middle income countries is delayed diagnosis, late referrals, and delay in initiation of the kidney support therapy. So that is why integration of these things with the ER physician is extremely important.
I think as I see that I've attended the programs with you when you've conducted them, that there's a lot of engagement of the doctors, and I think there's a lot of deep interest in improving their skills.
Yeah.
And also another thing is, I think it is like we are saving time for that child who can survive. I've also seen your pediatric intensive nephrology unit in Kalavati Saran Children Hospital. I think it has been established with a lot of thought behind it. So what was the need and the reason for establishing a unit like this?
I think one of the important reasons for establishing the unit was what we were observing. There are large public hospitals in our country where a lot of critically ill patients are coming with kidney diseases, both with primary kidney diseases and also children who are critically ill with other different organs. But later on have secondarily multi-organ failure with involvement of kidneys. And the pediatric intensive care units were already overwhelmed with general pediatric patients. And a lot of studies have also pointed out that endotracheal intubation in the ER itself in critically ill children is one of the risk factors of mortality. And delay in initiation of dialysis is a risk factor for mortality in these patients. So with the background of pediatric emergency medicine, we thought of starting a dedicated pediatric nephrology critical care unit at Kalavati Saran Children Hospital, and we were very thankful to the administration of the Kalavati Saran Children Hospital, including our head of the departments and colleagues in the department who allowed us and who helped us developing that unit. And we are running that unit for the last 4 years successfully, and I'm also very thankful to the Adharsila Foundation who have helped us in solving all the problems, teething problems which we had in the initial establishment, especially the equipments and all. And we are now treating large volume of critically ill patients in our unit. And recently we had two very important publications in the official journal of the International Pediatric Nephrology Association called Pediatric Nephrology, one on the lung ultrasonography and the other on outcomes of patients who are mechanically ventilated, and also on dialytic therapy. And we want to continue this training aspects to our students who can further establish more such unit across the country so that patients get the dialytic therapy in time. They should not be traveling thousands of kilometers with a creatinine of 15 and 16 when a lot of kidney function is already gone.
I think in your experience, you must have seen so many children.
Yes.
You're not being able to reverse the kidney injury because they have come late to you.
Even, madam, it has been seen that they recover initially, but long-term follow-up over 5 to 10 years down the line, they can develop proteinuria, hypertension, chronic kidney disease if you follow kids of these suffering from acute kidney injury. So that is also important. That is why, as Dr. Abhijit has highlighted, initial management is very crucial for their survival and maintaining the residual kidney function. And as you know, that we have started this skill-based training program, and many miles to go in the future.
What is your vision, Doctor?
Uh,
Abhijit, on this?
I think we'll continue with India is a vast country with
Yes.
so many cases of kidney disorders, and I think a whole lot of things needs to be done to bring down the mortality because of acute kidney injury. And at this point of time, I would also like to acknowledge the support of Indian Society of Pediatric Nephrology. In many of almost all of our training programs, we get help from the faculty members who are part of the Indian Society of Pediatric Nephrology, and our emergency medicine background people, the Indus EM Foundation.
I think as I see today, like I was also not aware of so much work needs to be done in the
Yeah.
pediatric nephrology field. The Harsha Renal Care Project was initially conceptualized more towards adult nephrology, but then now with the growth of pediatric nephrology project within the framework and the impact of this capacity building program, I think we can make much wider impact. So thank you so much
Thank
for
you very much.
building this and
Yeah.
taking it forward pan India.